Good morning, George Crawford. When I got asked to do this talk, it was a little weird. You know, when someone asks you in private practice, are you successful? You kind of laugh the first time and you think about it, I'm like, I'm still not sure. So I kind of changed this talk a little bit, and it's more, can one be successful in general surgery? That's me, that's where I am. Full disclosure, I have to leave this up for 7 seconds so everybody can read it. Basically, Ethicon, Galvani, Regional Medical Center, they don't pay me anything, but it makes navigating private practice easier when you're on the hospital board. And TLC, we'll get into that a little bit later. What is success? Everybody's a little different. If you want to make a lot of money, that's fine. If you like peace, that's fine. But the hardest part is deciding what you want to do. That was the first thing that I did when I went and started my own practice. Now, the one question everybody wants to ask you is, how much do you want to make? It's always the same. No matter who you ask, I want to make $1 million. If you want to make $1 million, general surgery, you're either doing something illegal or you're doing something else. As far as the average general surgeon, Anderson, Alabama is right outside of Atlanta, Georgia, kind of halfway between Birmingham and Atlanta. So the average is about $290 to $550. The people that are doing $550 traditionally have gone into bariatrics. So they're doing about 5 to 10% of their practice doing sleeves or whatever. As far as the starting salary, right now it's about $350. That's probably about $100,000 more than it was when I started 15, 20 years ago. And relative to everybody else, we're doing okay. Marriage, maybe that's your definition of success. You can try if you want to. Everybody knows we're not good at it as general surgeons. It's kind of how it goes. I tried it. I completed my first marriage 5 years ago. I have no timeline on my second marriage. But it's funny because general surgeons are always getting married. Even when we get divorced, we get married again. Just keep doing it, keep doing it. I guess it's kind of like trying to figure something out. As far as hobbies, I think as a general surgeon, you have to have a lot of hobbies. For me, that takes precedence over my practice. That was something that I didn't learn in residency that I had to appreciate afterwards. For me, I always tell everybody I'm an artist who funds my artistry by general surgery. So that's where most of my money goes. I actually have a studio in my office that I can do stuff in between cases, because some of the stuff I do takes a while. And I've got a couple of commissioned artworks that I have to do right now as well. I got to do it when I get back. Anyway, from an academic standpoint, we all talk about educating students, residents. I haven't started with residents, but medical students, yes. I'm fortunate to have a DO school right up the street from me, and I am one of the faculty members on that DO school, so I always have students with me. I also am a volunteer faculty for the UAB PA school. For me, my educational goals pretty much are accomplished by YouTube. When I was a resident, I think my attending, I think it was Dr. C.Dan Smith, said we're about to do a hiatal hernia repair. I didn't know what the heck he was talking about. Knew about it in the book, and I tried to go to YouTube because it was new then to look it up. Couldn't really find a video. So that's kind of one of the things that I've always wanted to do, is to create a library of videos that residents could go look at and say, hey, this is what I got to do tomorrow. Sorry going through these slides pretty quickly, but y'all get the gist. Interacting with colleagues. General surgery, private practice, you're isolated a lot. It's just you. You really don't even operate with your partners a lot at a time, so you have to get out and meet people. For me, I just did it through Prof Ed. Ethicon, they actually pay me to talk to people about stuff like this, which is crazy, but they do it and I take the check. As far as Storts, I do some stuff for them. Galvani, GSK, do stuff for them, and Da Vinci, I said no. As far as solo practice versus group practice, I guess we'll talk about that a little bit. It depends on who you are. You need to know if you're the person that can sit in the background, let somebody tell you what to do, have to argue every time you want to get rid of an employee, or if you just want to get it done. If you're like, she needs to go, she's out, he needs to go, he's out, I need to do this, we need to start doing more of this or less of this. And I think if you have that conversation with yourself early, that will save you a lot of headache as far as joining practices and not joining practices. As far as whether or not your office is successful, ask your staff. Y'all are laughing, but it's true. Yeah, it's you may not want to know what they tell you. That's my office. But they'll tell you if you're successful or not real quick. For me, success is how easy is it for a patient to get into my office? Can they see me? If they want to leave, do I make it easy for them to leave? Staff, are they quitting? Are they not quitting? Am I paying them well? Right now, it's do I pay better than Publix? That's the joke around the office, because I had to give everybody a raise because Publix was paying more for bagging groceries than we were in my office, so they got a raise. But fortunate for me, I fired one employee after 3 months because she was horrible. But other than that, I've had the same staff since 2008. Haven't fired anybody. I've had one get married and move, and that's it. As far as how to make it successful for you, there's small things. So you can give everybody a specific task, or you can tell everybody, just kind of, this is what you're supposed to do, but help everybody. So we kind of run it as a community practice, not as you do this, you do this, you do this. And we try and make it easy for patients to get in and out. And dealing with disgruntled patients, we kind of alternate, so we don't make one person do it all the time, because nobody wants to get yelled at all the time because they become miserable, or they're in general surgery residency. I think you get yelled at all the time there. Whether or not the patients get what they need when they leave, that determines whether or not they will come back. So if they have to have 3 or 4 phone calls after they leave your office, they're not going to come back and see you. Versus as soon as they walk out that door, they know what date they're doing the surgery, they know what their pre-op is, they'll come back. And when they come back in a small community, their father comes back, their grandmother comes back. As far as success in general surgery from a private practice, this is the one I'll spend a little bit more time on. That's my setup for a laparoscopic cholecystectomy. I don't have a lot of instruments. I don't use a lot of stuff. If I want a quick turnaround, I need to have a quick setup. I need to make it so the people in the operating room can get everything done pretty quickly, so I don't have to yell at anybody. We're surgeons. We know we yell from time to time. Learned behavior from our residency program. Anyway, I separate success in the operating room for me into 3 phases. The first one is pre-op. Is my H&P done? Are my orders done? Do they have any questions? We answer all of our questions ahead of time. The people in the patients, their family members can call anytime before surgery. We get it answered. That saves me a lot of time and headache in the beginning. With regards to the operating room, I call it the ergonomics of operating. It's not just how you're standing. It's whether or not you have the right table, whether or not you have the right stuff in the room. It's not as simple as the PL that they pull. It's as simple as making sure that your nurse knows what you're doing. If they don't pull the bookwalter when you're doing a lap chole, they don't have to count the bookwalter when the case is over. That saves you 5-10 minutes worth of time. So make sure, for me, it's just using the same team over and over again. That makes it easy. That was a common bowel duct exploration I did. Do that a lot of stones. As far as post-operatively, it's the same routine for me. As soon as I walk out the operating room, nobody talks to me, they don't look at me, they don't even ask me questions. I sit down at my desk, I do my orders, I do my post-operative note, I write my prescription, and then they can ask me questions, and I move on to the next patient. So I don't do the disappear thing that we all do in between cases because we have free time. I make sure that my stuff is done because that gives me a quick turnaround. Because I can push them instead of them pushing me. Have you done your orders? Have you done this? As far as postoperative care, that's up to you. I do all mine for the most part. I have medical students and residents that help. It decreases the phone calls, but it is what it is. How do you bill successfully? I put other word in there, and I didn't, but don't fall asleep on your billing. You'll have problems like people increasing deductibles, and that decreases the amount of revenue that you get from January to March. Around April, it picks back up. Locum tenens, I think that's something that we'll have to talk about at some point in private practice because it's going to be more important as it comes down the line because there's a shortage of general surgeons. We are not training as many as we used to, and we need more. But it's complex. As far as the general surgery shortage, it's coming, it's there. This is a list of the locum tenens jobs in the United States from just one company. So they're out there, it's gonna get worse. We need to train more, but we're not. So if you're in general surgery and you're thinking about doing private practice, you may be a locums doctor. Bunch of other stuff, but my time has run out, so I'm done.